Hello again. I'm Dr. Phil Rosenfeld, professor of ophthalmology at the Bascom Palmer Eye Institute and course co-director of the Angiogenesis, Exudation, and Degeneration annual meeting, which was just held. As you know, New Retina Radio partnered with Dr. Kitchens to moderate discussions from speakers who presented at this year's event. This is the final episode covering the 2021 Angiogenesis meeting. Check your feed for our other two episodes, which covered the future of therapy for geographic atrophy and wet age-related macular degeneration. In this episode, we strike at the heart of what makes the Angiogenesis meeting so great, a focus on early phase studies that may guide our understanding of how we will care for our retinal patients in the future. Dr. Kitchens sits down with doctors Nadia Waheed and Charles Wykoff, who share some phase 1 data with listeners. After the break, Dr. Kitchens moderates a discussion about how the future of our retinal practices involve innovative approaches for the treatment of retinal diseases, as evidenced in the two talks from our panelists.
I'm John Kitchens, and I'm joined today by Doctors Nadia Waheed and Charles Wykoff. Dr. Waheed is an associate professor at the Tufts University School of Medicine and is also the chief medical officer at Gyroscope Therapeutics. How are you, Nadia?
Great, John. Great to be here.
Thank you. And Charles Wykoff is with Retina Consultants of Texas and Retina Consultants of America. Thanks for joining us, Charlie.
Great to be here with you, John.
After we hear from each of you about your presentation at this year's Angiogenesis meeting, I'd like to zoom out and consider what early phase research says about the future of retina. Not just what it says about future therapeutic options, but also what it says about the operational framework of our field. But before we get there, we have some data to discuss. Dr. Waheed, you shared the interim results of the FOCUS study. Tell us a bit about that.
So the FOCUS was a phase 1-2 study which evaluates the safety and dose response of GT005 for the treatment of geographic atrophy. And GT005 is an AAV2-based investigational gene therapy. It's administered subretinally, and it induces the production of complement factor I. So the big takeaways from my presentation were that GT005 has been well tolerated in humans at the 3 doses tested. And that the administration of GT005 resulted in increased vitreous complement factor I levels and also statistically significant and sustained downstream reduction of markers of complement activation in the small cohort of patients tested in this early phase 1 clinical trial.
You know, Nadia, we've been hearing a lot about the complement system now and how complement inhibition could result in a therapeutic effect for some patients. But you said the levels of vitreous complement factor I increased following the dosing of GT005?
Yeah, so that is correct. So within the complement system, we have one down regulator, and that's complement factor I. So you really want to increase the levels of complement factor I to down regulate the rest of the complement factor amplification, especially the alternative pathway. And GT005 seeks to increase the expression of complement factor I in order to downregulate what may be overactivation of the alternative pathway.
Okay, so complement factor I then is a good thing when it comes to AMD and may actually decrease some of the bad complement factors that we've heard about, C3 and C5?
Absolutely. And the exciting piece is that we're using an investigational gene therapy to do that. So we know that there are variants in multiple complement genes, including complement factor I, that are associated with the risk of developing AMD. And we know that most patients with advanced AMD are genetically predisposed to an overactive complement system. So if you increase the expression of complement factor I, which is the natural downregulator, we hypothesize that we can restore balance to an overactive complement system, reduce inflammation, and hopefully in the long term, slow down the progression of macular degeneration and thereby preserve sight.
Nadia, fascinating biology, and you describe it beautifully. Tell us a little bit more about the FOCUS study itself.
So sure, FOCUS is a phase 1-2 open label study that has dosed 22 patients as of December. As with all phase 1 studies, we aim to assess the safety and tolerability of the therapy. We also wanted to understand if, and really to what degree, complement factor I would be upregulated following dosing. So we measured increases in CFI levels and changes in pharmacodynamic markers in the vitreous samples of treated patients. Now, there's 7 cohorts planned in the study at Angiogenesis. I presented the interim results from cohorts 1 to 4, and of these cohorts, enrollment is complete in cohorts 1 to 3 and is ongoing currently in cohort 4.
Nadia, tell us a little bit about the safety.
So overall, the 3 doses of GT005 were well tolerated. There were no GT005 related serious adverse events noted. What was interesting, we had one patient who was suspected to have a choroidal neovascularization at the 6-month follow-up, successfully treated with anti-VEGF therapy. Additionally, keep in mind that the gene therapy is delivered via surgical approach, and there were 12 surgery-related adverse events, again, none of which were serious. And importantly, we also saw no signs of drug-related inflammation. So overall, a very reasonable safety profile.
This is interim data from an early phase trial. We really need to be cautious about efficacy results. But with that in mind, what did you find?
Great question, John. So 9 of the 10 patients treated with GT005 had increases in vitreous complement factor I levels with an average increase of 146% compared to baseline. In fact, the first patient we treated showed sustained increases in complement factor I at 84 weeks out, which is the last sample that we have on that patient. Additionally, and very interestingly, what we noticed was that there was downregulation of the markers of alternative pathway amplification, including downregulation of the C3 breakdown products and of BA. These levels continued to decline up to the 48-week time point tested. And what was also really interesting was that we saw statistically significant linear correlations between the increase in CFI levels and the decrease in BA levels.
It's really fascinating, Nadia. What's on the horizon for GT005?
So John, as you know, these were interim results from the phase 1/2 focus clinical trial. So that trial is continuing to enroll patients right now. But in addition, the 2 phase 2 studies, Explore and Horizon, have also been initiated and are continuing to enroll. And these are really the studies that will answer the questions about clinical efficacy. So we hope to see, so we hope to continue to enroll in these studies over the next year or so.
Great stuff, Dr. Waheed. Let's move over to Dr. Wykoff. His presentation was titled Inhibition of Complement C3 in Geographic Atrophy with NGM621 Phase 1 study results. Charlie, we'll get into the specifics of the drug in a second, but first let's hear an overview of the study's goals.
Thanks, John. Absolutely. So this was a phase 1 study looking at NGM621, which is an inhibitor of C3 cleavage. There are sort of 2 key points in complement and the complement cascade: C3 cleavage and then C5 cleavage. And NGM621 is a monoclonal antibody targeting C3 that basically inhibits its cleavage. And the primary goal of this study was very simple: it was to evaluate safety and tolerability of both single and multiple injections of this monoclonal antibody, NGM621. And we also sought to explore the pharmacokinetics of NGM621 to guide the phase 2 study.
So Charlie, what type of patients did you enroll in this study?
The enrollment criteria here were pretty standard for an early phase geographic atrophy study. Patients had to be 50 years of age or older. They could not have a history or presence of CNV in either eye. They had to have geographic atrophy lesion size in the study eye of at least 2.5 millimeters squared. And then they had to have vision of between 2080 to 2400. We were targeting sort of the worst side of vision here because we were not expecting to see benefit. This was really a safety and tolerability analysis.
So Charlie, before we go further into the study design, let's hear about NGM621. Give it to me on the molecular level.
Yeah, NGM621 itself is a 150 kilodalton humanized monoclonal IgG1 antibody with a modified FC domain. This antibody has no pegylation and has a KD of about 340 picomolar, indicating high affinity for C3, given its ability to inhibit C3 cleavage.
So Charlie, we've heard a lot about complement, C3, C5, complement factor I. There's so many places to target the complement system in GA. If listeners want an in-depth discussion of the complement system, they can go back and listen to episode 1 of this miniseries and hear about C3 and C5 from Dr. Praveen Dugal and Dr. Voss Sada, and they discuss it. But Charlie, tell me, what are the benefits of targeting C3 as NGM621 does, and how does it differ from APL2?
Yeah, great questions. Yeah, the complement cascade is fascinating and incredibly complicated. I learn more about this cascade every time I think about a new molecule, a new mechanism. We're still learning a lot about this cascade. The truth is, we don't know what the optimal point is to intervene. Maybe it's to upregulate complement factor I, or upregulate complement factor H, or downregulate cleavage of C3 or C5 or CD59. There's so many elegant places to potentially intervene, and we are still learning what's going to be valuable for patients here. But specifically C3. C3 is the point of convergence of all three activation pathways. So it's sort of the first key location where everything that drives complement activation comes together. And then when C3 gets cleaved into C3A and C3B, that creates a downstream waterfall that ultimately leads to C5 cleavage and the MAC complex formation. So C3 is sort of the most upstream, conserved, central path of complement. And so the idea is that if you inhibit C3 cleavage, you can really shut down activation from any of the three pathways. And that's why it's a key point that's being investigated by multiple sponsors in this space. And you mentioned APL2 or pegcetacoplan, which has strong phase 2 data and is in a fully enrolled phase 3 program for which we should have data later in the year. And then this is a molecule early in the development cycle. Here, this is again just phase 1 data, also looking at C3 inhibition. APL2 is a small bicyclic molecule, again with positive phase 2 data. And this is much earlier on, but a slightly larger molecule without pegylation in an antibody form. We know antibodies are in general well tolerated inside the eye based on previous experiences with multiple other anti-VEGF agents, obviously. And so this is just another molecule in the pathway, and it may be differentiated here, but additional data is needed to determine that.
Fantastic explanation, Charlie. So back to your study. Give us a brief outline of the trial design for the listeners.
Yeah, it's a pretty simple, straightforward, clean phase 1 study. There were 3 single ascending dose cohorts, 5, 10, and a maximum dose of 15 milligrams. And that was followed by a multi-dose cohort of 15 milligrams dosed twice, 1 month apart. All patients were followed for 85 days. Of interest, all patients completed the phase 1 study. There were 15 patients total. Just a standard phase 1 study, limited in number of patients and limited in follow-up, very consistent with other phase 1 trials. On average, baseline vision was about 20/250, so poor visual acuity. Most of these were large, central involving GA lesions, which is what you would expect based on the enrollment criteria.
Charlie, it's always interesting looking at the safety in phase 1 clinical trials. What did you find in this particular study?
Yeah, thanks, Nadia. There were really no safety events that were of concern here, either systemically or locally in the eye related to study drug. In fact, there were no safety events attributed to study drug, just to say it clearly. There were no vision-related safety signals, no endophthalmitis cases, no inflammation cases, no cases of CNV development. But again, remember, this was just a 12-week final endpoint. And all of the ocular adverse events are representative of what you might expect following intravitreal injections, such as conjunctival hemorrhage.
So Charlie, clearly, this is a phase 1 study. The most important thing is, as you said, the safety. But I'm curious, what was reported as far as outcomes?
Yeah, absolutely. So we did look at all the standard outcomes. We did not expect to see a change in visual acuity or GA lesion size. And in fact, we did not see a change in vision or GA lesion size. Patients, again, were followed for about 12 weeks total in this phase 1 study. Mean IOP was also stable. We saw transient increases in the IOP, just as you would expect from a fixed volume injection into the vitreous cavity, as we're well aware of for over a decade at this point. And then, probably the most interesting take-home point here from a data perspective is really looking at the preclinical modeling data, which suggests that NGM621 at a 15 milligram dose may have biological activity able to suppress complement cascade activation for up to 7 or 8 weeks, sort of supporting a 2-month dosing interval moving forward, in addition to a 1-month dosing interval as we move into phase 2.
So that leads me perfectly into my next question. What's next for NGM621?
Yeah, NGM621 is being evaluated in a large, randomized, double-masked, robust phase 2 trial. The trial's name is Catalina. It's currently enrolling, and patients are being randomized equally to NGM621 monthly, NGM621 every other month, or sham injections either monthly or every other month. And the primary outcome is both safety and efficacy at 1 year.
Fantastic. Listen, I want to thank you both for sharing these really exciting and encouraging phase 1 data. We're going to take a break, and when we come back, we'll talk about what this all could mean for our patients and our practices. Welcome back to New Retina Radio's coverage of the Angiogenesis 2021 meeting. I'm John Kitchens here with doctors Nadia Waheed and Charlie Wykoff, both of whom just shared early phase data that they presented at this year's Angiogenesis meeting. I'd like to use these two data sets as a jumping off point, so to speak, about the future of retina. Innovative and creative thinking is needed to push our field from the anti-VEGF era toward an era where more patients can receive the therapy for additional diseases like we talked about tonight with geographic atrophy and dry age-related macular degeneration. Nadia, I'd like to come to you first. And one of the things that I really love about Gyroscope is their delivery of their gene therapy product. Can you describe how you're doing your drug delivery or your gene therapy delivery?
Absolutely. So, John, we have a surgical subretinal delivery, and it's a one and done surgery. So at the outset, right now, the FOCUS study has looked at subretinal delivery using a transvitreal route, which is your standard going in and doing a vitrectomy, creating a retinotomy, and delivering in the subretinal space. However, what we also have is a subretinal delivery device, and that is getting investigated in cohorts 5 to 7 of the FOCUS study, which is a minimally invasive device that basically travels along the suprachoroidal space and then goes into the subretinal space without having to do a vitrectomy and without breaching the vitreous necessarily. So the goal is to avoid some of those complications that you would get traditionally with a vitrectomy. It's interesting because one of the advantages of gene therapy is you deliver it. In this situation, you deliver it right to the cells that need it, which are the RPE cells and in the subretinal space. And then the hope is that the gene therapy continues to produce what you ask it to produce, in this situation, complement factor I, and therefore you have a long-lasting effect because of the gene therapy delivery. And I think that becomes important, especially when we're addressing diseases like geographic atrophy, in which patients don't see an immediate improvement in their vision once you give them an injection. Very different from anti-VEGF, right? Where you do a couple of injections and patients come back and they're like, I can see better. This is different. This is preventing decline of vision loss. And so I think, sustaining monthly or every other month injections in these patients in the absence of any visible benefit will be really hard to do, which is why I find, the subretinal gene therapy approach very attractive as a platform for delivery of almost anything, really.
Nadia, you hit on a great point. And one of the things that was really exciting about what you talked about was just the sustained levels of complement factor I elevation and gene therapy product after a single dose. We're familiar with this delivery device. People may have seen it presented at other meetings. I believe Janssen was one of the, with their cell therapy, this suprachoroidal delivery approach, and it's been spun off into the company Orbit, I believe. And it's a very elegant way to deliver a gene product. Now, you all chose AAV2 as your viral vector. What was your thought process?
Yeah, no. So one clarification, John. So even though the cannula travels along the suprachoroidal space, the delivery with the Orbit is true subretinal delivery. So you're actually delivering between the RPE and the retina, which is exactly where you would want this kind of gene therapy to land. But one of the reasons for choosing AAV2 is because it's clinically predicated. We have very good data on it out of the Nightstar and the Spark programs that have shown that, it transduces RPE cells, it produces what it's supposed to produce. And also there's very good data on longevity of effect. So you have 3-year data coming out from some of these programs still showing that the AAV2 is continuing to produce the proteins that it's meant to produce, which is one of the reasons that we started out with AAV2 because of that. Now, of course, keep in mind that this is a first generation, right? So eventually, there's a lot of exciting work being done on capsid technology. Not just by Gyroscope, but by a lot of companies that are really focusing on capsids, as well as on delivery, right? So I think the eventual goal will be to have a capsid that's available for perhaps in clinic delivery. And I think that eventually we will get there, but that's going to take, I think, many years more of development. And this is something that we know is clinic ready as far as the vector, the AAV2 vector is concerned. So it's a nice, safe platform to use that's been clinically predicated and approved by the FDA before in other programs.
Fantastic. Charlie, you gave us a great outline of the complement cascade and innovation of complement cascade by various different products that we've heard about at Angiogenesis and on this podcast. Do you think that there will be a role for multiple drugs inhibiting complement, or do you think you just need to block it at one point or another and stop the entire cascade?
I wish I had a great answer to that, John. It's a super important question, and I just want to see at this point one drug that's approved. I mean, we've had so many strikeouts in this field for so long, right? You think of the lampalizumab hangover that we're all still living under. Sorry to use that analogy, but I think it's true. That was such a letdown for patients first and foremost, but just for the whole field, that I would take any drug approved at this point. I'm very excited about the APL2 data. I think that was strong phase 2 data. I'm particularly excited about that in the face of the Zymura data from their phase 2b/phase 3 trial. We have 2 complementary data sets that are showing a similar magnitude of benefit over 1 year. So very excited that we really are onto something for patients' benefit. But then you ask an important question. Okay, if the C3 inhibition with APL2 works, are we done? And I think the clear answer from my perspective is no. I mean, we need to differentiate these molecules, these pathways. We need to understand, are they synergistic, or are they going to be somehow not synergistic? Well, one will be enough. And then you got to think outside of complement, right? We have HTRA1 inhibitors, totally separate pathway, that are 2 of those in development, very exciting. And then other approaches, right? Other approaches to treat GA also, ultimately regeneration of the lost cells. So I think there's a lot of work to be done here. The first step will be to slow the progression, and then we can go earlier in the disease state and really begin to look more broadly at this disease state. But at this point, I would take anything in the clinic.
Great point, Charlie. One of the advantages you mentioned about NGM621 is the potential that it could be a 2-month drug. How are we going to get patients to buy in to monthly or every other month injections indefinitely to treat something where they're not going to see an improvement in their vision?
Yeah, super important question. And sort of two threads I take away from that. First of all, they're anti-VEGF agents. We have the perfect, VEGF meter in the OCT that was developed at the same time. Such serendipity there. We don't have that. At least we don't think we do with GA, right? It's going to be treat fixed dosing indefinitely, at least with these first 2 molecules in phase 3 trials right now. And there's really no endpoints. Now, who knows? From the phase 3 data set, maybe we will be able to tease out certain phenotypes or maybe genotypes that can be dosed less frequently and continue to have benefit if we structure additional phase 3b studies, for example, to study different dosing frequencies. So we might be able to individualize over time, but top-line phase 3 data will not allow us to differentiate from monthly dosing versus every other month dosing. I mean, the good thing about the Apellis data set is that we are going to have different dosing frequencies. And so we'll see if they're equally effective. And of course, if they are, patients and physicians will choose to use the less frequent dosing. But we will see with data over time.
And Nadia, from a visualization standpoint, are there going to be any parameters or metrics that we're going to be able to follow, like we follow OCT for anti-VEGF, to kind of give us and our patients the feeling of some modicum of success in these treatments?
So that's a great question. And it goes back to what Charlie was alluding to. The top line phase 3 data is really not going to answer those questions for us, but we just need to get a therapy in clinic at this point, right? Because these patients are going blind in front of our eyes. But I think some of the work that's being done in imaging and that was presented at Angiogenesis was, as well as some of the work being done in machine learning and artificial intelligence, I thought was really, really interesting, because I think at this point we're really trying to parse out, which are the patients who are fast progressors? Which one of these patients are the ones that, are there any predictive biomarkers out there, such as the choroid capillaris, or looking at, hyperreflective spots in the retina that may predict which patients are worse prognostically, and therefore enable us to target these patients and follow them and actually show some effect. I thought some of the most interesting data presented actually out of the Apellis clinical trials was around nascent geographic atrophy and how they inhibit the development of nascent geographic atrophy, right? So I think we're certainly moving into the era of looking at some of these earlier biomarkers and being able to parse those out and to be able to show that we're having an effect. But a lot of work still, I think, needs to be done in that realm. And we really need to invest in understanding the disease and the disease process and progression better, and going in sooner and earlier to really prevent vision loss.
Nadia, for GT005, what's our timeline on that? When would we expect to have some ability to have this in clinic?
So that's a great question. And, as a clinician, I think we really understand the urgency of getting therapies to these patients, which is, one of the reasons that, at GT within Gyroscope, we've actually started our phase 2 trials in parallel to the phase 1-2 still enrolling, because we just wanted to get patients into this as soon as possible. So, I think the phase 2 enrollment is ongoing and we should have some good answers. And of course, we're working as fast and as hard as possible to get these studies enrolled. So hopefully soon, not too far out into the future.
Fantastic. Charlie, same question for you on NGM 621. When might we expect to be able to hear some phase 3 data and anticipate this coming to our clinics?
It's a long-term down the road. I mean, right now we're enrolling a phase 2 trial across the United States. And so, right, you think that that's a 1-year primary endpoint. You're looking, maybe we have data on the phase 2 in 2 years. And I am not involved on the sponsor side and when to move forward with phase 3, but just my experience from other programs in the past is probably wait to see data from the phase 2 before initiating the phase 3. So you're looking at multiple years down the track. I think that the next most exciting thing to me in GA is going to be the Apellis phase 3 readout, anticipated for potentially third quarter this year.
Yeah, that is something that's really, really exciting and that is on the horizon. So speaking of other exciting things on the horizon, aside from your subject matter and what you talked about at Angiogenesis, Charlie, what were some exciting things that you heard at this really, I think, best Angiogenesis meeting ever?
I agree. It was a fantastic meeting. I love the all live format. That was a bold move. I think it paid off great dividends there. I think to me, the most clinically relevant topic, I'm a little biased because I was involved with it, but it's the faricimab data. I really do think the faricimab is meaningful because we have positive phase 3 data on an additional mechanism of action, right? We lived in the anti-VEGF monotherapy world for so long. It's a great world for our patients to have been able to live in, but could it be a better world moving forward now that we can inhibit Ang2 and activate Tie2 signaling? And I think the answer looks to be yes, based on the phase 3 data. But it's not a commercial product yet, but presumably the sponsor is going to submit that to the regulatory agencies. That I think they've said publicly that they're planning to do that in the near future. And so hopefully in the not too distant future, we'll have another toolbox, another tool in our toolbox for these common exudative retinal diseases. It's the first time ever we've had 2 global phase 3 programs read out at the same time for the same molecule. So very exciting to see that move forward in both DME and AMD.
And Nadia, same question for you. What were some of the things that you were fascinated by at Angiogenesis?
So I think the answer for me is 2 big trends that I'm starting to notice. So one is, as an imaging person, really seeing the imaging and the biomarker and the AI field take off. and really starting to see us trending towards a way of designing smart trials instead of huge clinical trials that are very expensive and last forever. So smart and acceleration, and I think we've started seeing that in the in some of the imaging biomarkers that are getting parsed out, right? I think the other piece that I found really exciting was this this leaning in towards longevity of treatment, right? Because I think all of us know we've done, these monthly or every other month injections in our, diabetic patients and in our wet AMD patients, and there's only so much that you can do with that over the long term with chronic disease, right? And we've seen lots and lots and lots of data come out that show that compliance goes down over time, and therefore, you start seeing the efficacy declining over time, and the outcomes get worse. So this real leaning in to providing longer-term therapeutics, from my perspective, whether that be gene therapy, whether that be the port delivery system, I thought all of those, were really exciting trends, and of course, seeing the progress driven forth in geographic atrophy. So looking at both the Apellis data and the Iveric data and seeing two completely independent data sets acting on the same pathway, but at different points in the same pathway and still pointing in the same direction with the same magnitude of effect. For me, that was huge, right? Because just like you said, we're suffering from the lampalizumab hangover. And I think this, to some extent, helps pull us out from there and really move forward in this field.
Well summarized, Nadia. I got to agree. I think this was a fabulous meeting. There's never been a meeting where we've just had so much data presented. And honestly, I think next year we may see even more, which is just so exciting that our field is moving forward so quickly. Nadia, Charlie, I want to thank you both and congratulations on your really great presentations. That's it for this episode of New Retina Radio's coverage of the 2021 Angiogenesis meeting. Go back and listen to earlier episodes covering Angiogenesis 2021. Until next time, I'm John Kitchens. Thanks for listening.